Hello, everyone. We are going to discuss chest pain and how I handle these symptoms, and we're going to keep it simple as a nurse. So, your patient is complaining of chest pain. What should you do? Now, I will discuss a series of steps that I go through to determine if the chest pain is stable or unstable. First, you want to get a good description of the chest pain. The acronym I commonly use is OLD CARP. Means onset, L means location, D is for duration, C means characteristics, A is aggravating factors, R is relieving factors, and P is pain scale. Now here is a sample table that I use to distinguish if my old carp is stable or unstable. Red would likely be unstable, yellow can go either way, and green is likely stable. So you want to ask, when did this chest pain start? And what were you doing at that time? Where is it located? It could either be precordial, meaning on top of the heart, or sternal, you mean it's in the breastbone, or costochondral, meaning on the ribs, or diffuse all over the chest. And you also want to take note of how the patient shows you the location, whether they point with their fingers or with Levine's sign. Duration means if it is constant or intermittent. Characteristics can either be stabbing, aching, burning, sharp tightness, or whatever the patient described the chest pain is. You also want to ask what makes it worse or aggravating factors, or what makes it better or relieving factors. And lastly, you want to ask the pain scale from 1 to 10. My next step is to ask the patient, what other symptoms are you feeling? If they mention dizziness, syncope, presyncope, headache, palpitations, diaphoresis, anxiety without any stressful events, then their chest pain may likely be unstable. Dyspnea may either be stable or unstable, and cough, dysphagia, bloated, belching, hiccups, nausea and vomiting, anxiety with stressful events are most likely stable associated symptoms of chest pain. You also want to briefly ask about their history. High risk for unstable angina are history of diabetes, Raynaud's phenomenon, recent upper respiratory infection, or if the patient is a smoker or has been using illegal drugs. And likely causes of stable angina are recent trauma or unusual activity involving the chest, recent stressful events, or recently eating spicy or acidic foods. Now, after reviewing past medical history, next thing I check is the vital signs. And with the use of my stethoscopes, I would listen for friction rub, which is a sign of pericarditis, which is common in chest pain. Then I would also inspect for jugular vein distension. And lastly, I would try to see if I can reproduce the chest pain. Usually, reproducible chest pain is stable, and unreproducible chest pain is likely unstable. After obtaining the pain description, associated symptoms, history, and doing your nursing assessments, I would have a suspicion of what the patient conditions would be. Here's a table I use to correlate the nursing assessments with the patient's condition. If the chest pain is described as diffuse, precordial, patient is complaining of chest pain at rest, or may have dyspnea, dizziness, diaphoresis, or having anxiety with no stressful events, patient might be suffering from acute coronary syndrome. If the patient has chest pain, dyspnea, and recent upper respiratory infection, I might be thinking of myocarditis. If the patient has dyspnea and you hear a friction rub, which is aggravated by supine position and relieved by leaning forward or using anti inflammatories, then I would lean towards pericarditis. Chronic chest pain that is greater than 2 months and described as diffuse, which is aggravated by stress, exertion, and relieved by rest, I would think of stable angina. Patients points chest pain to sternal, which is aggravated by eating foods and relieved by antacids, I would lean towards GERD. Chest pain with recent trauma, unusual activity of the chest, or has a cough, I would lean towards muscle strain. If chest is tender to touch and pain is reproducible, I would lean towards costochondritis. Or if the patient is having chest pain aggravated by stressful events or emotions, I would lean towards anxiety attacks. When I ask the doctor for labs, I would consider the time the patient presented with the chest pain. If it is less than 24 hours, I would ask the doctor for myoglobin to be drawn every 4 hours. I would report to the doctor if it is greater than 72 nanograms per milliliter or an increase of 40 nanograms per milliliters. Myoglobin can be elevated while other cardiac markers are not because myoglobin is the earliest cardiac marker which lasts for 24 hours only. Other cardiac markers that I would request from the doctors are CKMB, which is good from 48 to 72 hours from the time of presentation, and troponin INT, which is good for 14 days from the time of presentation. CKMB is every 4 hours and a value greater than 4.9 nanograms per ml or an increase of greater than 1.6 nanograms per ml. I would be notifying the doctor. However, CKMB can be false positive if the troponin I is abnormal. It's not abnormal. Troponin INT is good for 14 days. However, troponin I is the gold standard. The timing is also every 4 hours, and if the value of troponin I is greater than zero point 0.4 nanograms per ml, the patient will be considered high risk. I would also request the doctor for pro-BNP and a value of greater than 400. I would notify the doctor. And other labs I would consider will be CBC to rule out for any infection and ESR to rule out costochondritis. When the doctor orders for EKG, I would report if there is any ST elevation. ST elevation occurs when the J point is elevated by one small box on the limb leads or two small boxes on the precordial leads. Here is a sample of what the J point looks like, and this is when the ST elevation is which is when the ST elevation is going horizontal. And here are my resources. Thank you very much.